Thank you for joining me today for this in-depth session on Barrett's esophagus. I will explore this condition in quite detail, from the very basics of what it is to the complex interplay of molecular mechanisms, the diagnostic approaches, the clinical decision-making and management strategies. Along the way, I will also share some important historical context, practical insights, and emerging research directions that are shaping how we understand and then treat the disease. Introduction to the Barrett's esophagus. Barrett's esophagus is a fascinating yet concerning medical condition because it represents a pre-malignant transformation in the esophagus. In simple terms, the normal squamous epithelial lining of the lower esophagus is replaced by a type of intestinal type of columnar epithelium. It is a typically consequence of long-standing gastroesophageal reflux disease, or GERD. Now, why do we care so much about Barrett's esophagus? Because this metaplastic change is considered a precursor lesion for esophageal adenocarcinoma, a cancer whose incidence has been rising significantly over the past few decades, particularly in Western populations. The idea is that Barrett's esophagus doesn't guarantee you will get cancer, far from it, but it raises your risk substantially compared to the general population. Now, the historical backgrounds of Barrett's esophagus. The condition was first described by the Australian thoracic surgeon Norman Barrett in the 1950s. Interestingly, Barrett initially believed that the columnar lining of the esophagus was actually part of the stomach that had somehow been pulled upwards, a theory that was later corrected by further studies. Over time, histological evidence clarified that this was in fact metaplasia, a transformation of one type of epithelial tissue into another type better suited to the harsh acidic environment that is caused by chronic reflux. Now, the epidemiology. Epidemiologically, Barrett's esophagus is the most common in middle-aged to older adults, with a higher prevalence in males than in the female population, than in Asian or African populations. Though incidence is rising globally as lifestyle pattern changes. Key risk factors of Barrett's will include chronic GERD, central obesity, smoking, and a family history of Barrett's or esophageal adenocarcinoma. The pathophysiology. The pathophysiology of Barrett's. Let's discuss what actually happens inside the body. Normally, the lower esophagus is lined by the stratified squamous epithelium, which is good at handling mechanical stress. For example, when food passes through, but not so good at resisting prolonged acid exposure. In GERD, acidic gastric contents repeatedly splash back into the esophagus, damaging the squamous lining. In response to this chronic injury and this chronic inflammation, the body adapts. And I will use adapt cautiously by replacing the squamous cells with columnar cells that can actually better handle acid and bile. Now, what the catch is that these columnar cells also have goblet cells, which are not normally found there. They're usually in the small intestine or the large intestine. This is why it is called intestinal metaplasia. Unfortunately, this adaptation comes at a cost that the new tissue has a higher chance of undergoing dysplasia and in some cases progressing to adenocarcinoma. The clinical presentation. Interestingly, many patients with Barrett's esophagus are asymptomatic and they do not present with any particular signs and symptoms. But what they often experience are symptoms of underlying GERD, heartburn, regurgitation, and sometimes difficult swallowing, that is odynophagia. However, it is important to note that some patients with Barrett's have minimal or literally no reflux symptoms. That's why Barrett's is often diagnosed during endoscopy for another reason, such as evaluation of persistent reflux, anemia, or dysphagia. Now, the diagnosis of Barrett's esophagus. Diagnosis of Barrett's is made through upper gastrointestinal endoscopy. On endoscopy, the normal pale squamous mucosa is replaced by reddish salmon-colored mucosa that extends from the gastroesophageal junction. However, Visual impression alone is not enough. Biopsies must be taken to confirm the intestinal metaplasia with goblet cells on the histological pattern. The Seattle biopsy protocol is often recommended for it, that we take 4-quadrant biopsies every 1 to 2 centimeters along the suspected Barrett's segment. This maximizes the chance of developing, finding any lesion of any dysplasia. The classification. Now, Barrett's can be classified in several ways. By length, that is a short segment Barrett's, that is less than 3 centimeter of affected mucosa. Long segment Barrett's, that is more than 3 centimeter of affected mucosa. By histology, that is non-dysplastic intestinal metaplasia, low-grade dysplasia, and high-grade dysplasia. The risk of progression to adenocarcinoma increases with the grade of dysplasia. The risk of malignancy. Non-dysplastic Barrett's carries a smaller annual risk of adenocarcinoma esophagus, roughly about 0.1 to 0.3% per year. However, once dysplasia develops, especially high-grade dysplasia, the risk jumps significantly to as high as 6 to 10% per year. This is why surveillance is so important. The goal is to catch dysplasia or cancer early when treatment is much more effective. Now, the management of Barrett's esophagus. The management depends on the degree of dysplasia and on the symptoms. If there is no dysplasia, the main aim is to control the reflux symptoms, that is the gastroesophageal reflux disease. And this can be done with a lot of lifestyle changes and proton pump inhibitors in drugs, PPIs. Endoscopic surveillance is typically recommended every 3 to 5 years if we develop a low dysplasia segment. For a low-grade dysplasia, endoscopic eradication therapy such as radiofrequency ablation, that is RFA, is now preferred over just surveillance. As studies have shown, it reduces the progression to adenocarcinoma esophagus. High-grade dysplasia, endoscopic mucosal resection, that is EMR, combined with radiofrequency ablation, or in selected cases, surgery such as esophagectomy may be needed. Lifestyle modifications. Lifestyle advice is critical. Elevating the head of the bed to prevent regurgitation or esophageal reflux that causes the Barrett's esophagus in the first place, avoiding any late night meals, reducing intake of acidic, spicy, or fatty foods, weight loss for overweight individuals or people who have central obesity. They are more prone to Barrett's esophagus or GERD in general. Emerging therapies and research. Now, ongoing research is looking at a lot of biomarkers that might predict which Barrett's patients are most likely to progress to cancer. Molecular studies have identified changes in tumor suppressor genes such as P53 and abnormalities in DNA content, that is aneuploidy. These may one day guide individualized surveillance intervals, like after how many days or after how many months or years we need to survey the patient for any dysplasia. Endoscopic therapies have evolved tremendously, like cryotherapy, hybrid artery plasma coagulation, and novel imaging techniques like narrow band imaging, NBI, and they are refining detection and treatment. There are now that to sum up, Barrett's esophagus is a condition that sits at the crossroads between benign reflux disease and malignant transformation. While not all patients will progress to adenocarcinoma esophagus, the elevated risk makes it a condition that deserves our attention, careful diagnosis, and structured surveillance. Barrett's esophagus is chronic and progressive condition in which the epithelium, normal stratified squamous epithelium of the distal esophagus undergoes a pathological transformation into a metaplastic non-ciliated mucus-secreting columnar epithelium with specialized intestinal metaplasia. Especially now, there are also role of CDX2, that is a transcription factor that is involved in intestinal differentiation alongside accumulation of genetic mutations that affect tumor suppressor genes like TP53 and CDKN2A. That is, epigenetic alterations that together destabilize normal cell cycle control. The diagnosis of Barrett's esophagus requires continuous endoscopic evidence of columnar appearing mucosa above the gastroesophageal junction. And this, by the presence of, and this intestinal metaplasia can be also seen on staining or histopathology, like on staining with hematoxylin, eosin, Alcian blue, PAS staining. And now for the three, there are also new classifications like Prague C and M criteria, which describe the circumferential C and maximal extent of metaplasia. Once diagnosed, management strategies are tailored to the degree of dysplasia found. Patients with non-dysplastic Barrett's are typically managed with long-term proton pump inhibitors, therapy, weight loss, dietary adjustments to avoid reflux triggering foods like caffeine, chocolate, alcohol, or fatty or spicy foods. Eating smaller meals, avoiding lying down within 3 hours after eating, elevation of head, and proper surveillance of the same. Now, if a person is surveillance at a particular right time, the risk of carcinoma of esophagus, which is a lethal cancer in the society, can be significantly reduced. And in especially now the Barrett's esophagus, now today, ultimately we can, in practice, in clinical practice, the management of Barrett's is a lifelong partnership, basically between the patient and the gastroenterologist, requiring adherence to the medical therapy, commitment to lifestyle changes, and willingness to undergo periodic surveillance, all aimed at intercepting progression before it becomes a life-threatening situation. Ultimately, Barrett's esophagus represents a paradigm of how chronic injury, adaptive metaplasia, and neoplastic transformation are interconnected, and it highlights the power of early detection, minimal invasive intervention in altering the natural history of a potentially lethal disease, ensuring that with modern medicine, most patients diagnosed today can expect to live full, healthy lives without ever developing cancer, provided they remain engaged in the ongoing care. Now, whereas is often, as clinicians, our role is to manage reflux, monitor for any dysplasia, and our role is to improve our understanding of the biology of this condition and develop further better ways to predict, detect, and treat it. Thank you all for all your attention.